Clinical presentation, like I said earlier, depends upon the presence of the VSD. The size is usually unrestricted, large. So that clinical presentation does not depend upon the position of the VSD but the size of the VSD. So presenting as unrestricted VSD, as heart failure, failure to thrive. So they have increased pulmonary blood flow. That means if we are going to postpone the surgery for more than 6 months, they will require pulmonary artery banding to prevent pulmonary vascular obstructive disease due to increased pulmonary blood flow. Presence of PES means reduced pulmonary blood flow. So there is no banding required. Early closure of the VSD by tunneling, intraventricular tunneling is the surgery required. No PS, then PA banding or early surgery for VSD closure or intracardiac tunneling repair. So TOF, they present DORV type of TOF present like TOF. So there is no newborn cyanosis. Cyanosis starts after 1 week. Presence of TOF spells, TET spells like any other TOF. TGA presents as newborn cyanosis and heart failure. TGA type of DORV. Remote VSD is like a VSD with increased pulmonary blood flow. X-ray depends upon the presence of pulmonary stenosis. So either as a TOF, typical boot-shaped heart also is possible with reduced pulmonary blood flow, reduced pulmonary vascular markings restricted to less than 1/3 of chest fields, or presence of plain VSD or TGA can present as cardiomegaly with pulmonary hyperemia. ECG similar to TOF but two different patterns. One is in TOF we have the sudden transition from V1 to V2. Prominent R pattern which transits, the transitioning happens abruptly. So there is the abrupt transition from V1 to V2 in TOF, which may or may not be present in DORV. They definitely have RVH, some amount of RVH, but the sudden transition is classically not seen in DORV. The two classical patterns are presence of counterclockwise rotation, that is, presence of deep Q waves in lead 1, AVL, V5 and V6, and presence of slurred S wave in presence of slurred S wave in AVR. So initial Q wave in high lateral leads and presence of slurring of S waves in AVR. This is one finding. The other finding is PR segment prolongation. Because of the location of the VSD, there is some stretching of the AV nodal conduction tissue. So there may be PR segmental prolongation in DORV. So there is the transition. It is not classically as in TOF. In TOF, V1 is the tallest followed by V2 transition. Here the tallest is being V2. There is RVH definitely. It is not TOF. Presence of Q wave, very classically present in lead 1, AVL, V5 or V6. So this Q wave, counterclockwise depolarization is very common. Followed by slurring of the S wave, in AVL, not AVR. Slurring of the S wave in AVL. This is a classical pattern of DORV with or without PR segment prolongation. By echo, like I said earlier, the entity DORV is defined by aortic mitral discontinuity. So I say aortic mitral discontinuity because the commonest pattern seen is the TOF pattern where the aortic valve is committed to the LV. So in TGA pattern, when there is subpulmonic VSD, there is a pulmonary mitral discontinuity. So there is discontinuity between whatever the AV valve and its committed great artery. So the mitral valve, whichever the committed great artery is, if it is a TGA, the pulmonary valve is discontinuous from the mitral valve. So the mitral valve starts here and the aortic valve starts here. This is the discontinuity diagnostic of DORV. And then there is a presence of the large VSD which is almost committed to the aortic valve. So this is a TOF type of DORV. This is a other type. So this is a subcostal view. This is the RV and aorta 100% pulmonary artery, 100% is committed to the RV. So definitely DORV, and the VSD is present below the pulmonary valve. So this is the subpulmonic VSD, the pattern commonly seen in TGA. There is additional finding, there is a large PDA, the flow of which you can see here. Here, since it is a TGA type, like I said earlier, this is the pulmonary valve because it will bifurcate here. This is the aortic valve. So this pulmonary valve is discontinuous from the mitral valve. You can see the level of discontinuity here. So here the pulmonary valve is discontinuous from the central fibrous body because of presence of the conus tissue, which makes it superior.